Swallowing, we don't really consider a reflex anymore. That way back when we started in dysphagia, swallowing was reflexive behavior. And because of that, all of our rehabilitation approaches were compensatory in nature because we thought you can't change a reflex. You could do a video fluoroscopy on a patient, see reduced hyoid movement. Your brain wants to think, oh, they're weak. Let me strengthen floor of mouth. But we also have reduced hyoid movement, not due to weakness. That's when you have issues of motor planning or motor control.
So where does this research come in? Research. Welcome to the Dysphagia Research Bites podcast, which is a podcast designed to make dysphagia research more clinically digestible for speeches, especially those working in home and community-based settings. My name's Chantal, I'm a speech pathologist, and I started this podcast because dysphagia care doesn't just happen in hospitals. It happens around kitchen tables, in aged care facilities, and in everyday life. Community dysphagia work is complex, it's nuanced, and it's often underrepresented in conversations about swallowing. So, if you're looking for clinical tips and thoughtful, evidence-informed conversations that actually translate to practice, you're in the right place. Today we're joined by Professor Maggie-Lee Huckabee, who spent 15 years as a clinical SLP before the frustration of not knowing the answers led her to research. She's now a distinguished professor at the University of Canterbury in Christchurch, New Zealand, where her work focuses on behaviourally driven neural adaptation and biomechanical change in swallowing recovery following neurological injury. In her 20-year academic career, she's published 132 peer-reviewed papers, written 15 book chapters, co-authored 3 books, with one releasing in its 4th edition this year, and has been recognised with the Royal Society of New Zealand's MacDiarmid Medal for her commitment to translational research. Professor Huckabee is passionate about getting research out of the lab and into the clinic. She's the recent founder of Swallowing Technologies and an invited speaker to health systems worldwide, where she provides clinical training, particularly in rehabilitation practices. And the article we're basing our discussion around today was published in 2023 and is called The Evolution of Swallowing Rehabilitation and Emergence of Biofeedback Modalities. Maggie-Lee is the first author, and I anticipate a lot of our discussion is going to focus on not only biofeedback, but this topic of strength versus skill-based rehab. Welcome, Maggie-Lee.
Thank you very much. I'm glad to be here.
Before we jump into some of the specifics in the article, what I want to do for listeners is I want to clarify something. So I know we're going to be talking a lot about sEMG, which stands for surface electromyography. Hang on. How about you tell me what sEMG stands for?
sEMG is the acronym for surface electromyography.
Thank you. I actually asked a few speechies on my Instagram account a little while ago about sEMG and what they thought about it. And something surprising that happened, or maybe it's not so surprising, it was confused quite a bit with something called NMES, which is neuromuscular electrical stimulation. So before we jump in, would you be able to clarify the difference between these two things?
Absolutely, I can. Surface electromyography records the electrical activity in a muscle that's produced during contraction. Every muscle, in order to contract, you have electrical activation of the muscle. So surface EMG is a measurement device that we maximize that information in rehabilitation to use it as a biofeedback device. So in treatment, the patient is using that signal for feedback so that they can modify swallowing behavior. Neuromuscular electrical stimulation uses the same types of electrodes, and they may be placed in the same place. However, neuromuscular electrical stimulation puts a current into the muscle as a means of exciting muscular contraction or neurological function. But and the big point of difference between those is that one, you're stimulating the patient, but the patient isn't necessarily participating in the process. The other approach, the patient is stimulating their own muscles and modifying that through feedback.
Yeah, great. I haven't thought about it that way as well, but yeah, that makes sense. I think a lot of people had mentioned, they hadn't used sEMG and felt it was something that still might be a little bit controversial. And I thought, oh, hang on, I think they might be talking about NMES. So Maggie-Lee, can you just give a bit of an overview of this article we're going to be discussing today?
Sure. This article, I had a great time writing this article with my co-authors. I think that one of the benefits of getting older is you can see where we've come in dysphagia management, which I think informs the future. And there is a quote in the article by Steve Jobs: "You can't connect the dots looking forward. You can only connect them looking backwards." And I think that is so relevant to where we are in swallowing. What we've done with this article is we've mapped out how our understanding of cortical control of swallowing has developed in the last 5 decades. What research has come in to let us better understand that, swallowing, we don't really consider a reflex anymore. That way back when we started in dysphagia, swallowing was reflexive behavior. And because of that, all of our rehabilitation approaches were compensatory in nature because we thought you can't change a reflex. If it's a reflex, it is what it is. We compensate for the problem. As we've moved forward and we've started to understand that the cortex has a modulatory contribution to swallowing, so we started looking at things like understanding that, yes, it might be a reflex, but we can strengthen the muscles associated with swallowing. So we moved from compensation to muscle strengthening, still with the idea that it's governed by a reflex. We may be able to moderate that, but it's still governed by a reflex. Most recently, the research is documenting that there are very complex cortical neural networks that underlie swallowing behavior. And we know that cortical motor planning regions are very involved in setting up a swallowing response. And so, with that sort of transition into thinking, yeah, swallowing may not be a reflex, it may be in large part a cortical network generated behavior that transfers down to the reflex. Well, now our rehabilitation approaches have shifted dramatically. We have lots of things like non-invasive brain stimulation techniques where we're not even dealing with the brain stem, we're stimulating the cortex directly. And the idea of stimulating the cortex directly is you're upregulating neural inputs. And that's also where the role of skill training for swallowing comes in. That if we know, if we recognize now that the cortex is involved in governing a lot of swallowing behavior, then we can manipulate the cortex. We can work on more voluntary type behaviors by changing the timing, by changing the relative strength, by changing the organization of the components of the pharyngeal swallow. So that's sort of the crux of the article, is it sort of follows this timeline through of looking at how our knowledge of swallowing has altered our rehabilitation approaches. And that gives us, with the involvement of the cortex in swallowing, we have so many more options for rehabilitation.
And do you think that this knowledge or this research has transferred into sort of everyday knowledge of clinicians?
Boy, tough question because I don't work as an everyday speech pathologist, but I think that there is a dent in the understanding of that transition into cortical control. But it still has a long way to go. And, as I said earlier, I'm still learning as well. Everybody is still learning about this. It just takes time to translate things from the research lab to clinical practice. And I
Mm.
think as long as clinicians are open to change, which I think the majority are very welcoming of it and hungry for it, then I think that we ultimately will get there. We're just not quite there yet.
Yeah. Yeah, that infamous, what is it, 17-year research to practice
Exactly.
gap. Mm.
Exactly.
What I want to talk about is, this idea of skill versus strength training. Um, and I'm wondering if you can define for us what is a skill-based problem with swallowing, because I think we understand as therapists what a strength-based swallowing issue is, but can you please explain what a skill-based impairment looks like?
Sure. I think, we have for so much of the development of swallowing, we have considered dysphagia to be a disorder we couldn't amend, so we worked on muscle strengthening instead. And indeed, there are patients who are weak. All patients with myopathies will be weak. If you have a lateral medullary stroke, they will be weak. If you have a patient who has a cortical stroke that has impacted the pyramidal pathways, they will be weak. That's upper motor neuron. And so if you disrupt the upper or lower motor neurons, you get weakness. So certainly we do have weak patients with dysphagia. However, if you think about other etiologies like Parkinson's disease, right? If you look at all of the fundamental characteristics of Parkinson's disease in the limbs, you might have, or speech, actually, you might have bradykinesia, you might have hyperkinesia, right? So you've got all these characteristics of motor impairment, but there is nothing in the diagnostic of Parkinson's disease that says weakness. However, most of our rehab approaches for Parkinson's are based on strengthening. So, so I think what we need to do as clinicians is really start opening up and thinking, here's my patient with dysphagia. Do I have clear evidence that there is asymmetrical weakness in this cranial nerve exam? If you do a good cranial nerve exam, you can detect weakness, right? Absolutely. You ask the patient to open the jaw to resistance, the jaw deviates to one side. You've got weakness of the trigeminal nerve. So it makes absolute sense to work on head lift maneuvers or chin tuck against resistance, EMST, all of which are muscle strengthening exercises for the floor of the mouth. However, you could do a video fluoroscopy on a patient, see reduced hyoid movement. Your brain wants to think, oh, they're weak. Let me strengthen floor of mouth. But we also have reduced hyoid movement, not due to weakness. That's when you have issues of motor planning or motor control. So, cranial nerve exam, I've long been a very big proponent of doing very thorough cranial nerve exams because your cranial nerve exam will help guide you to what I see on clinical or instrumental exam. Is this due to weakness? Well, if the cranial nerve exam is normal, which we have a lot of patients with normal cranial nerve exams, they're still dysphagic. Well, don't do muscle strengthening on them because their exam has told you they're not weak. Instead, you need to think, what do I need to do with these patients that will develop a more appropriate and efficient motor plan for swallowing?
Hmm. Yes, I definitely learnt the importance of doing a cranial nerve exam from your intensive dysphagia course.
Good,
Um,
thank you.
So, is that what you would say to clinicians? That's really what we need to be using if we don't have access to sort of other tests that will actually tell us how strong a muscle is. Is that what we should be using to help us determine whether this is strength versus skill?
I think so. I think in many, many cases, if you've done a very thorough cranial nerve exam, and if your cranial nerve exam is normal, but they're still dysphagic, I would not do muscle strengthening. I
Hmm.
would work on some other aspect of skill-based training. If there is unilateral weakness that's evidence of cranial nerve exam, then I would focus on muscle strengthening.
Would you be able to explain or give an example of a particular skill-based deficit that we would see in dysphagia?
You bet. A lot of my thinking about impaired skill has been driven by one patient, who I saw not recently, probably I saw her in 20, oh gosh, 4 or 5, I guess, 2004 or 5. She was a fairly young woman who had a massive brainstem stroke during childbirth. By the time she came to me, she was 2 years post onset. She had gotten rid of her feeding tube at about 6 months, but she was still markedly dysphagic with significant post swallow pharyngeal residual. When I saw that post swallow pharyngeal residual and I looked and saw decreased hyoid movement, I thought, okay, well, here's the problem. We've got reduced hyoid movement. Because of that, there's reduced UES opening. She's got molecular residual and piriform sinus residual. So if I go in and work on floor mouth muscles and work on effortful swallows, I should sort this problem. So that's what I did. I put her in a treatment protocol to sort out that problem. It did not sort out the problem, it just exacerbated it. So I did manometry on her, where you put a small tube in the nose, through the nose, into the esophagus, and it measures pressure. And what we saw with manometry is that when she swallowed, the pressure generated in the pharynx was absolutely fine. She had good force generation. The problem was when she swallowed, she contracted all of the pharynx at the same time. So rather than a superior to inferior pressure wave, she had simultaneous contraction. Because of that, she had diffuse residual nasal redirection. Muscle strengthening is going to do nothing to help her. All it's going to do is exacerbate the nasal redirection. So she's a really clear example of where the motor program has become disrupted, right? I've consequently brought in about 16 patients that presented that exact problem. And they did very, very well with skill-based rehabilitation.
And would you say that for identifying skill-based issues, we would always need to do an instrumental like a video fluoroscopic swallow study?
Well, I believe, and I know that most clinicians that work in the community don't much like me for this, but I think I believe similar to very many people that work heavily in swallowing. You cannot do rehabilitation if you don't understand the problem. And a clinical swallowing assessment, although it is critical for interpreting your instrumental assessment, a clinical assessment by itself is not going to get you where you need to go. So I think that instrumental exams are absolutely critical in setting up a treatment plan. Otherwise, you don't know what you're doing. You have no idea what the problem is.
Yep, that makes sense. You also mentioned in the article that strength training can be contraindicated in some patients because it runs the risk of reinforcing deficits like pharyngeal missequencing. Is that the example that you just gave before? Because I was going to ask you, yes, what pharyngeal missequencing might look like.
Right.
Um, On video fluoroscopies, you gave the example of you use manometry with that patient. Is it something that we wouldn't be able to see on video fluoroscopy, the pharyngeal
Right.
missequencing?
So when we look at missequencing, or if we look at appropriate sequencing in individuals, healthy missequencing, there is about a 230 millisecond gap between contact of the pharyngeal walls at the upper pharynx to the lower pharynx. 233 milliseconds. You can't see 233 milliseconds when your fluoro screening rate is 30 frames or less per second. You just can't see it. What can give you what missequencing looks like on video fluoroscopy is you tend to have diffuse residual. Some of the bolus goes through into the esophagus, some goes through into the airway, some goes up through into the nose. That nasal redirection in the presence of velopharyngeal closure is quite common with missequencing.
That makes sense. Um, Now, can you talk to us about the role of sEMG, how we would use that in a swallow rehab program?
Sure. Well, let's take for an example a patient with Parkinson's disease, right? If you see a patient with Parkinson's in the community, and these patients, some of them are newly diagnosed, some of them are a little bit later. But when we look at them and try to watch them eat on both clinically and on video fluoroscopy, we see a lot of extraneous lingual movement where they're trying to manipulate the bolus, trying to get control. If you think of the way they walk, their tongue looks just like their feet. Little bitty shuffling movements that aren't very effective, right? Then when they swallow, they may have decreased pressure. They may have molecular residual. They may have adequate pressure, but it looks really disorganized relative to where the bolus is in the oral cavity. I think that the use of surface EMG works beautifully with patients with Parkinson's disease. You put the electrodes underneath the chin, so you're measuring the anterior belly digastric, mylohyoid, and geniohyoid. Then you ask the patient to swallow. Now, when they get ready to swallow, typically what we see as evidence of all that lingual pumping is the EMG signal has lots and lots of little peaks, a lot of activity before they actually elicit a swallowing response. So you use that signal. You tell the patient, oh, look, I asked you to swallow once, and I see 8 little bumps on the computer monitor. I want you to swallow again, but the next time, if you have more than, let's say, 6 little bumps in your waveform, just stop. Don't even try to swallow, just stop. And then they practice that. And it's an amazing patients with Parkinson's disease have an amazing capacity for visual feedback to override motor behavior. I don't know if you've ever seen the videos of gait in Parkinson's disease where they just put markers on the floor and they start out with a little shuffling gait. They draw lines on the floor and say, step over, and they have a perfect gait. They use that visual feedback to moderate performance. And in swallowing, it's the same thing, except the visual feedback is in the form of a representation of muscle activity.
And does it work equally as well in patients with other conditions like stroke, for example, the visual biofeedback?
Yeah, I think, one of the approaches that I'm quite interested in right now is where you have the electrode under the chin, so you get your waveform on the screen, and then you give the patient a very distinct target. So in the software program that I use, there's a little square on the screen. The square pops up on the screen, and you tell the patient, I want you to really concentrate on swallowing. So they're recruiting cortical regions. And I want you, as you approach that little box, think about what you're doing. I want you to swallow just so the peak of the waveform falls in the box. So they're having to control the timing and the relative force generation required to elicit a swallowing response. The next screen wraps around and the target's in a different place. They may have to swallow quickly, but with little pressure. That may be a lot like a liquid swallow. You
Mm-hmm.
swallow quickly with not much pressure. So they watch the little target and they need to put the peak in the target. So I think in stroke patients, that is a very viable approach of having the patient really learn to stretch and challenge those neural networks in order to organize their swallowing response.
Mm. Now, I just want to talk a little bit about the actual device, how it looks. I know a lot of speechies are not able to visualize this if it's something they haven't come across before. I first started using it a few years ago. I was at a multidisciplinary private practice, and they had devices that physios and OTs were using. So when I first started using sEMG, I was using these small handheld devices. I know there are devices or programs that are designed specifically for swallowing, and I believe that one of them is yours, which is Bisc app. Can you please explain that to therapists so they have an understanding of what that actually is, how it might look, and how it's maybe different from other devices that you could use, like the example that I gave?
Yes, I am involved with commercialization of a biofeedback device, but I want to be really clear that stealing a device from physiotherapy can work just as well. The board of my business would not like that I just said that. But essentially, surface EMG is surface EMG. It
Hmm.
just is. So we don't like to use devices where your only feedback is on a handheld screen
Hmm.
because it's too small
Hmm.
and it's hard to see that time by amplitude waveform. So in the device that I developed and typically use, it uses a time by amplitude waveform that is displayed taking up the entire computer monitor. So it's a big screen and you can see what you're looking at. It has two protocols. One is a strength training protocol where you have little electrodes that are attached to an EMG unit. And in our device, the entire unit is about 2 or 3 centimeters in size, right? That sits underneath the skin.
Hmm.
It connects to the software or the app in the computer or a tablet. And when you do strength training, the waveform, the goal of the training is you tell the patient, I want you to swallow as hard as you can, do an effortful swallow, and make the peak of your waveform touch a threshold line at the top of the screen. So they swallow to try to hit the line. If they miss the line 3 times, the line drops back down
Hmm.
so it's more achievable. If they hit it 3 times in a row, the line goes higher. So timing is not an issue, and your focus is in the upper range of the screen. You want them to really swallow hard. The skill training paradigm is sort of as I described before. It's not focused on strengthening. You never want them to do an effortful swallow.
Hmm.
But there's a little roving box that moves around on the screen, a target. And you want the patient to really use their cortical networks to think about swallowing, to imagine swallowing, so that when they swallow, that target hits the box.
Hmm.
Again, if they keep missing it, the box gets bigger and bigger and bigger, so they're successful. If they keep hitting it, it gets smaller and smaller and smaller, so you have greater task challenge. This particular device is intended for home training so that you, as a clinician, will send the patient home with a sensor and with the app installed on their tablet, and then they can practice 3 times a day, 5 days a week in small bursts.
I remember something interesting in the article. I think you might have referenced some neuroimaging studies where they said that I think they did some research on maybe it was people with healthy swallows and got them to just think about swallowing without swallowing,
Absolutely.
and it activated the same areas as when
It
we
does.
do a swallow.
It does. And those are the pathways we're trying to strengthen. And, in sports medicine, that's been a very well researched and observed finding in sports medicine, where you'll watch athletes that are about to do the downhill ski slalom, and they're sitting at the top, and you can see them moving side by side. Their eyes are closed. They shift to the side, they quickly shift to the other side. They're mentally imagining that ski run and performing that. That's strengthening the neural networks. So when they go to do it, they've already done that over and over and over again. And there is research in swallowing on that same phenomena that when you think about swallowing, you activate the same neural network up to the point of activating the pyramidal pyramidal system to send the neural signal down for activation. So that entire cortical neural network is activated, just imagining swallowing.
Mm. And so when we're using something like sEMG, we're providing that extrinsic feedback. I just want to talk about intrinsic feedback for a second and
Mhm.
where that sort of fits into the picture. I have an example. I saw a client a few years ago, and her only diagnosis was she had long COVID. She had some swallowing problems. She was coughing whenever she had something to drink. She had a video fluoroscopic swallow study. It didn't show anything abnormal. Her swallow looked normal, but when you saw her clinically, there was lots of coughing when she was drinking. I started working with her and was just instructing her to really concentrate on her swallow and just try a few different things, trying a few different ways to see if she could swallow without coughing. And I got this idea from a few of my clients with multiple sclerosis. A lot of them have said that, when they really concentrate and pay attention, they're able to swallow a lot better. So I just wanted to ask where this intrinsic feedback sort of fits in and if there is some of this biofeedback stuff that we can do if we don't have access to sEMG.
Sure. Again, all that imagined movement is really critical. And what you've done is great. Think about the way that you're swallowing and really focus on swallowing. I think that intrinsic drive to swallow appropriately, certainly you could say if you just swallow over and over and over again, you'll repeat the same behavior. But you made an important point in that think about the way you swallow and how you might swallow differently. So we don't want them just repeating behavior, we want them adapting behavior. And so you could, I think anything you can do to increase that scenario is useful. Also, think about olfactory input. I used to have a patient named Rosie, and we'd open a bottle of red wine every time she walked in the door because she was Italian and she liked her red wine. So all sorts of visual feedback to let them think about swallowing, smells that make them think about swallowing. If you don't have the EMG specifically, as you just said, there's this great thing called the whiteboard. And you got a little whiteboard marker and you got your whiteboard and you say, okay, I'm watching you and I'm going to draw a line. And as soon as you swallow, I'm going to make the line go up and down when you swallow. So let's do it. Here you go. Whoops, up and down. See, there's your swallow that I drew on the line. The next time you swallow, I want you to make a little swallow compared to that one, right? So just do
Mm.
a little swallow. Think what that felt like, do it less. Here we go. You swallow. Maybe that one was about there. You draw where you think that was. Now, the next time, let's make it harder. I want you to swallow with effort. You swallow. There you go. Now, you take the pen. Show me what you did. Now, All of that is made up because, of course, you don't have an instrument measuring that. But you're making them think about what they're doing so they become more consciously aware of swallowing, and that's facilitating those neural networks.
Mm. Do you find, is there like a weaning off period from sEMG where people become too sort of reliant on it to be able to swallow in the right way? Is there a period of time where you need to sort of train them back to just focusing on, maybe that intrinsic sort of feedback, or they don't need it because you've done the training, it's been effective, and then they can just swallow
Yeah,
normally?
they just don't need it. And, I've had a lot of patients who have come to me for an intensive training protocol. So I maybe have seen them for 1 or 2 weeks, twice a day for an hour. And then I send them home because they can't stay forever and come for treatment twice a day for a few hours. So once we finish an intensive training course, I send them home. Some of them I tell them, here, do you want to take an EMG device home? Or I actually send the device home and I say, how's it going with your device? Oh, I don't actually use it because I can see on my eyelids what it is I need to do.
Mm.
So they have internalized that feedback. They
Hmm.
know what they need to do. They don't need the equipment showing them that because they can see it in their own mind what they need to be doing.
Yep. And are there any, or can you talk through some contraindications for maybe using sEMG for biofeedback? Who wouldn't it be appropriate for?
Yep, so this is where NMES and biofeedback differ in that there are unexplored potential adverse effects of NMES, whereas with sEMG, we don't know of any adverse effects of sEMG, except potentially you may have some patients like a radiated patient where the skin is very sensitive and friable, or a very elderly patient where if you put a sticky patch under the chin and then take it off, you might get a skin tear. Yeah, that's not good for those patients. But I guess when you look at who would benefit from biofeedback, my question is who wouldn't? And would you ever have a patient that you don't want to have visual feedback about the way they're swallowing?
The only patients that come to mind for me would be those who have a bit more of a significant cognitive impairment, because I imagine you do need a certain level of cognitive skill to be able to participate in this therapy. Is that right?
Yes and no. I mean, certainly there are patients with very severe dementia that are in bed and don't recognize their family members and that wouldn't be able to do it because they don't have the attention.
Mhm.
However, I always tell people relative to rehab, whether it's EMG or anything else, as soon as you decide that the patient can't do it, you have just tied that down and locked it in stone that you won't give them the opportunity. I've just finished, I'm working this morning on the fourth edition of a book, and I just got through writing a section. And in that section on biofeedback, there's a publication, it's quite an old publication, that it was a group of, this was in upper limb
Mhm.
training. And they took a bunch of patients with severe global aphasia who had right upper extremity impairment, hemiparesis, and they used surface EMG biofeedback in half of them. The other half just did regular physio.
Mhm.
And they found that those who had biofeedback had significant gains in upper extremity involvement. Essentially, language is not required to use biofeedback. You may have to take them step by step. You may have to start with, in a patient with a lot of cognitive or language problems, put a red rubber ball in their hand, put the electrodes on the forearm, and have them squeeze the ball, point to the screen, squeeze the ball, point to the screen. They need to understand what they are doing with voluntary behavior is showing up on the screen. Then you can move the electrodes to floor of mouth. Have them open their mouth wide. You have to contract floor of mouth to open it and have them watch the screen. See, they move the jaw, it moved the line on the screen. Then you can work them to swallowing. It may take 2 or 3 sessions for them to really get what it is you're trying to do, but it doesn't mean they can't get there because use of EMG is not, language is not necessary for the use of EMG.
I know listeners will be interested as well. What's the fourth edition? What book is this that you're working on?
Um, Dysphagia following stroke,
Mm.
that I've written the first 3 editions with Stephanie Daniels. We added a third co-author last time. And then it's now time to do another edition. Stephanie says, nah, I'm out. She's such a smart woman. Says she's retiring. So I've taken on the 4th edition with 2 new co-authors who are absolutely fantastic. Bastian Doltkin at Flinders University, and the other is Janina Wilmsketter, who's in North Carolina. After this one, I'm out.
You're
I'm done.
well, you've definitely contributed a lot to our field, so I feel
Thank
like
you.
that's okay. You're allowed to do that, right?
There you go.
Maggie Lee, was there anything else that you wanted to cover that we didn't talk about in relation to this topic of biofeedback or strength versus skill training?
There's so much to say, and I could talk for about another 8 hours if neither of us had anything else to do. But I guess sort of the big closing argument I would have isn't so much strength or skill. I do think it's important you differentiate what your patients need. So you're not trying to strengthen a patient who is not weak. That just doesn't make sense therapeutically. I think there is literature that suggests that if you do skill training, you will also get increases in strength. So my default position would always be to start with skill training and only do muscle strengthening if the skill training doesn't resolve the problem. That tends to be my default position. But I guess the big take home point is we've spent a lot of years trying to understand swallowing and trying to understand neural control of swallowing. I think we're getting there. I won't say we're there yet, but we know so much more than we did. And at some point, we've got to translate all that information and start doing rehabilitation. Um, it is so disappointing to me as a clinician, because I'm a clinician at heart. It's so disappointing to me when patients discharge from hospital on a pureed diet with thickened liquids and nobody follows them up and they're left that way. And I really want to encourage people to get out and try rehab. And if it doesn't work on the first try, then try again. And if it doesn't work then, try again. I think patients don't fail rehabilitation. We fail to know what patients need. So I really want to challenge everybody to, if you have those patients on your caseload that are kind of floundering, try again. Just try again.
And I know a lot of speech pathologists are really interested in rehab. They want to know more, they want to do more. And so I
Right?
think yeah, there's a bit of a mismatch between sort of what do I do? How do I do it?
Yep.
One thing I just want to ask you is about how a session might look in terms of repetitions, because that's something that's stuck in
Oh,
my mind from
sure.
your training as well, in that
Mhm.
it was made very clear that oh, we are not doing anywhere near enough repetitions when we're
That's
doing
right.
rehab. So can you just talk through that?
Sure. I don't know that there is a magic number. I do know as a clinician, I was a chatty old girl, and I spent most of my 45, 60-minute therapy sessions. Poor patient, I'd have him do some repetitions and then I'd talk a lot. And I learned quite a few years ago. I learned that if I want my patients to get better, I need to shut up and let them work. Most of the patients I've seen for intensive training, we do about 100 repetitions in an hour of training. So they're doing a lot of swallowing. Certainly, not all patients can do that. That's too much. In a Parkinson's patient, I'd go 80 to 100 trials a session. In many stroke patients, they might make it up to that level, but I would start with low repetitions. Let's do 25 swallows this session. If they do 25, then the next session say, man, you did so great. Let's go up to 40. If they do 4, terrific. You're doing so well. Let's go up to 60. You always want patients to want more therapy than giving them too much at the start, and then they give up. But keep working on number of repetitions and keep challenging them and yourself to do lots and lots of repetitions.
Big thank you to Maggie-Lee. I don't know about you all, but I got a lot out of this episode. Thanks for tuning in to the Dysphagia Research Bites podcast. If you want more dysphagia education, then head over to Instagram at Dysphagia Community or www.dysphagiabites.com. Bye-bye. I stuffed up my chopsticks.
One thing that you